All right, so welcome everybody to the today's session about tractography, brain stimulation and white matter navigation. So I will briefly introduce the methods that we utilize for brain stimulation mapping with 50 Hz stimulation for behavioral responses, and also with single pulse stimulation about 1 Hz for evoked potentials, and how to track those responses. So let's have a look why we need brain stimulation at all. So basically we want to identify brain functions. So with the 50 Hz stimulation established as the Penfield method, we can for example inhibit parts of the brain during the speech process, or we can activate and cause motor movements during the stimulation. With the lower frequency of approximately 1 Hz, we get also evoked responses from the brain that we can measure, and usually with the cortico-cortical evoked potentials stimulation, we don't see real behavioral responses. So usually the patient can just sit quietly and then experience the stimulation, and we can read the evoked potentials from the cortex. And also in contrast to the electrical stimulation that shows behavioral responses, there's the risk of inducing seizures because of the stimulation. This risk is much reduced for the evoked responses stimulation. It's also possible to stimulate the peripheral nerve for somatosensory evoked potentials. This is very useful to localize the central sulcus, for example, in an intraoperative monitoring scenario. And then there are other modalities also for treatment of disorder, like deep brain stimulation, for example, to treat Parkinson's disease, vagus nerve stimulation to reduce the seizure rate in epilepsy, and responsive neurostimulation actually to sense and terminate seizures when they occur directly in the brain. And yeah, there are possible open and closed loop neuromodulation use cases for clinical research. Today I will basically focus on the electrical cortical stimulation and the cortical evoked potentials for functional mapping, and also the functional anatomical structure identification. So let's understand where these approaches are actually located in functional mapping techniques. So with electrocorticography, or EEG in general, including stereo EEG, we have the possibility that we can read biomarkers, electrophysiological biomarkers, directly from the brain. This is an observational method, and the cortico-cortical evoked potentials are part of this. We can also do it completely passive, so that we localize self-induced brain activity, as for example broadband changes in the high gamma frequencies, and by that localize task-related changes in the brain, similar to the hemodynamic bolt in fMRI. And with the evoked responses, we can reveal connected networks. And if we, for example, know the entry point of a stimulation that is already a functional region specific for a task, then we can associate the network to that task. On the other hand, we have inhibitory techniques like the 50 Hz stimulation, the electrical cortical stimulation, or in the operating room also the direct electrical stimulation with the handheld probe, the transcranial magnetic stimulation, or the WADA test, where we sedate the carotid arteria. And here basically we can suppress parts of the language areas, or induce auditory illusions or visual illusions, and by that inhibit the function that we want to actually perform. And this is a quite powerful tool during a resective brain surgery, just because we see which parts of the brain are quite necessary to perform a task. And on the other hand, we have the excitatory tools, and these are overlapping. So for the same protocol, the 50 Hz stimulation, and also for TMS, we can, for example, elicit motor movement. And by that, we can see which parts of the brain are actually sufficient to trigger a behavioral task like a movement. And for surgical decision making, it's of course very important to incorporate the inhibitory or simulating the lesion, because before the resection, then we can actually, for example, stimulate the brain during an awake surgery. That's one possibility here. It's also possible to do the cortical stimulation in the epilepsy monitoring unit, just to perform a pre-surgical mapping and understand if electrodes, for example, that are associated with the epilepsy foci are actually eloquent cortex or not. This is also sometimes dangerous because, of course, we can induce seizures. So in that sense, sometimes it's also very useful to first really screen that there is an eloquent part in the brain with the observational techniques, and also, for example, to start with a single pulse stimulation and see connected areas to avoid the risk of inducing seizures. So how does it work? Basically, the current will be injected into the brain, and it's very important that we consider which electrode is actually used for stimulation. So for the electrical cortical stimulation with 50 Hz, usually we have bipolar stimulation, so two neighboring electrodes in a distance of about 5 mm to 1 cm are stimulated. And here the injected charge, so the charge density, is actually what is causing the interaction with the tissue. So the volume underneath the electrode will actually have a lot of ions that are going towards the electrode surface, and by that they are causing an ion current in the tissue, and this can, for example, excite a particular function or inhibit the particular function. And for the excitation protocol, first we have a resting state and then a stimulation train that can last a few seconds, and then we observe any behavioral change in the patient and have to ask if they have any change in sensation or if there are any auditory or visual illusions that they perceived. And after the stimulation, the patient should return to the resting state, so the symptoms should diminish. For the inhibitory case, the protocol is slightly different. So here we have a baseline task, so to say, and in this case the patient is doing a language task or talking, and during the stimulation we will observe, for example, transient aphasia or similar effects like dysarthria or paranoma, and understand that there is a disruption of the speech network. And then after the stimulation, this should recover and the patient should be back in the resting state and be able to talk again. So this is now the clinical standard method that is actually used for functional mapping, and again, it can be used in a pre-surgical evaluation in the epilepsy monitoring unit or during intraoperative awake surgery direct electrical stimulation. What is the protocol? So usually phase durations of approximately 300 to 500 microseconds are used for biphasic rectangular pulses, and current intensities of 2 to 50 milliamperes can be defined. Important is that the electrode surface has to be considered when defining the current, so smaller electrodes also need a smaller current, because then the current density and finally also the charge density in the tissue will be increased for smaller sites or for smaller contacts. The stimulation is about 50 to 60 Hz and a few seconds of stimulation. And it's important to start at low stimulation amplitudes so that we can observe the symptoms, how severe they are, and also we can observe after discharges in the stereo EEG or ECoG signals, and this is an indicator that very soon a seizure can occur if we are further increasing the stimulation current. There are some safety aspects that we have to consider. So as I mentioned, the charge density per phase is actually the most critical parameter that we have to understand. And so for long-term stimulation, chronic stimulation, everything below 50 microcoulomb per square centimeter is considered as safe. And for short-term stimulation, so there are some transition densities, but in principle for our purpose, where we have stimulation periods of less than 10 seconds, we can go up to around 300 microcoulombs per square centimeter. And of course, the stimulation should not be long-lasting, so the stimulation pulses have to be very short, so less than a millisecond or less than a few milliseconds preferably, otherwise we will cause tissue damage due to electrolysis. So here is an example for a commonly used phase duration, so 500 microseconds minus and then 500 microseconds plus in an alternating manner. And then we have here for different exposed stimulation areas the current amplitude that we can actually set to have no harmful stimulation. And we can see here the green part is good for chronic stimulation, and for transient stimulation we can actually go here until the red area and not set anymore the dark red area. So this is kind of the safety threshold now. And we can see here from different manufacturers, so PMT is from the US, Unique from Japan, Cortec is from Germany, ETEC from US, NATO is also from US, Inomid from Germany, and here you can see for different probes and electrode surfaces the current densities and charge densities that are actually occurring. So you can see that here, for example, in Japan, the 1.5 millimeter diameter is still certified for clinical use, and this is the limit for the 15 milliampere stimulation. So if we go to the sub-millimeter space, then we are not allowed anymore to use the full range of the stimulator in this case. So we have to be careful in that sense. So we usually use the g.Estim Pro that we produce, and this is certified for the use of the 50 Hz stimulation for the functional mapping. And we can also utilize it in a research mode for higher stimulation frequencies or for the evoked responses. So here is a demonstration how this looks like. So here is the cortex on the motor area is actually stimulated during a reference period where the patient is doing a baseline task. And then we can see that the movement deviates from the baseline. So here in this case, we utilize the bipolar stimulation via the grid. So we have the anodic and cathodic stimulation basically alternating, and it's also possible to do it in the operating room with this handheld probe directly. So let's have a brief look how a stimulation can be actually conducted. So this is now the control software that we use for the Estim Pro. And in here we can set if we want to send a trigger to the outside, for example, to the amplifier to have the stimulation onset. We have to enter the diameter of the electrode, the exposed diameter, so that the charge density can be calculated. Then we can set the phase duration and the amplitude. So we will start at the low amplitude and set the pulse rate, and then we can activate the device and it's ready for stimulation. So when we stimulate, we have to be sure that the impedance of the electrode is sufficiently low. So this is indicated by low, and everything that is higher, for example, than a kilo ohm will be shown as a numeric value. And so it's important to understand that the higher the impedance of the electrode is, the higher is also the voltage that is applied. So we can stimulate up to 80 volts for a bipolar stimulation, and then the stimulator will indicate a high impedance and that it's not possible to stimulate the brain. So here we can now stimulate on the board, and we can see that there is an ongoing current monitoring and also a voltage monitoring. So here I basically used a jumper to shortcut the output, which is possible because it's a current stimulator, and then we can gradually increase the current and stimulate. So another example for a language mapping is a picture naming task. So here the patient is actually looking at an egg, which is in Japanese tamago. Here we can also see the activation map over the progress of the task. So first we have the visual perception, and then of the egg, and then actually we have the cortical high gamma dynamics, where we can see that the word is actually generated here in the lateral frontal lobe, and then also we have some oral motor related activation at the end, at the anterior temporal tip of the cortex, of the temporal lobe. And so now here she can talk quite fluently, and when she is now stimulated at the active regions, then you can hear in the buzzer sound the duration of the stimulation. So while she is stimulated, she cannot really say anything, and after the stimulation she will still be irritated what happened during the stimulation. So this is now a transient aphasia, and after the stimulation she can talk normally again. Another example is from a study that we conducted together with the MIT, with Nancy Kenwisher and also with Gerwin Schalk. And here we showed different shapes to the patient to understand whether or not the fusiform face area that we have localized with high gamma mapping can also be confirmed by electrical cortical stimulation. And by doing that, so here you can see the stimulation, the bipolar stimulation site on the fusiform gyrus, and by showing the different shapes. So here we have a rectangular box with a kind of a mosaic pattern. You can see here in the raw datascope there are some after discharges. So here we stimulated at 8 milliamperes, 1.5 millimeter exposed diameter contacts. So this is the edge, for example, in this patient of the current intensity. And now he experienced just for 1 second that a face appeared on the box. So now we can see the stimulation artifact again in the raw datascope. So finally the doctor turned into an anime character, and interestingly, for all the different shapes it was also possible to have the face illusion. And now he's looking at the kanji character. So this nicely showed how we can understand how specific brain regions can be identified. So the stimulation had to be repeated several times. That makes the procedure a bit complex, but this is required for this real separation between the different illusions to really pinpoint the specific part of the brain. So here now we stimulated a color-specific region that was also identified by grayscale and colored images, first in the high gamma mapping. And again, the visual illusion could be reproduced in all the 4 tested objects. And here you can see an overview about different current intensities that we have utilized for stimulation in terms of the thickness of the connected line, and also the symptoms that occurred throughout different parts on the stimulated cortex. And very interesting is, for example, here that in 5 patients always the motor mapping gave a positive response, whereas, for example, the visual illusion mapping here showed visual percepts that could be explained by the patients in 3 cases, where in 2 cases the patient didn't really show any visual illusion, although similar sites have been stimulated. So this makes it very difficult to systematically do functional mapping with sensation and illusions and perception in general, because it creates a complex protocol and also relies on the ability of the patient to really explain what they feel, what they see, what they hear. But despite this, the cortical stimulation is actually very beneficial for the cross-total resection outcome, and also to prevent severe deficits after the surgery. So from this meta-analysis from the VITAMA, we can actually see on more than 1,000 patients for each group that we have a very significant, or that we have significant reduction of the severe deficits from 8% to 3%, and also an improvement of the cross-total resection for those glioma surgeries that have been conducted with intraoperative ECS mapping compared to those without. So that means that when we add functional mapping, it's actually we can perform a more aggressive resection with a better functional outcome. And of course, there are severe adverse events which we have to consider. So here, for example, from 90 studies, about 3% reported patients with seizures, and in general, the seizure rate is about 10% for intraoperative mapping in general. And this is how it can look like. So here there's the cortical stimulation mapping ongoing, and now we can see, while we record the electrocorticography during the stimulation, that first of all the stimulation artifact is visible here now in the raw data scope, and now the patient is asked to perform a task. And then after the stimulation, we can actually see that the seizure starts. So during the epilepsy monitoring, this is of course a small problem, but not a big problem, because the patient anyway undergoes seizures frequently. In the operating room during an awake surgery, of course, this is a bit more complicated. So usually icy water has to be splashed over the open brain so that the seizure can be terminated. And if it can be terminated, of course, the surgery can be continued. Otherwise, there's an obstruction of surgery. A more safe methodology is the cortico-cortical awake potential with the single pulse stimulation. So single pulse means about 1 Hertz. And so one famous entry point is Dr. Matsumoto's study about the cortico-evoked potential in the language system. So here we have actually the frontal language area where we experienced, for example, during the stimulation mapping, the speech arrest or aphasia, and then there are some face motor related areas and language related areas, and when stimulating one part of the network, it's actually possible to see anatomically connected functional regions. So here, this is a very prominent N1 with the negative axis downwards. So we have the N1 and the N2. So the N1 is quite the early component, occurring between around 20 to 50 milliseconds. And then we have a later component at around approximately 100 to 300 milliseconds. And here we have the stimulation entry point on the lateral frontal cortex again. And then we can see here the oral motor related sites. And when we stimulate the same place and we record from the lateral temporal cortex, then actually we can see here on the more posterior part of the inferior temporal gyrus, of the superior temporal gyrus, sorry, we can see here those responses with the N1 and the N2 waveform. So now let's have a look how to conduct a cortical stimulation experiments for evoked potentials. Again, we will go to the stimulator software, and now in the advanced mode we have more free options that we can define. For safety, we can also utilize a foot switch. So when we step on the foot switch, the stimulation will be active, will be allowed, and otherwise the stimulator stops immediately if we step off the foot switch. So for the CCEP, we utilize now a monophasic stimulation, and the polarity has to be alternating. This is very important because if we use a monophasic stimulation with a steady polarity, non-changing, then there is the risk of gradually upcharging the tissue, and we don't want to do that. So we want to have a net zero charge in the tissue, and by that we apply an alternating polarity of the stimulation. Another effect of the alternating polarity of the monophasic stimulation is that we can actually have an artifact, the stimulation artifact, with the opposite direction, and by that we can get a better understanding what is a physiological response and what is actually a stimulation artifact. So in order to record now the evoked potentials, we can utilize the recording software, the g.Recorder, and together with amplifier, a g.HIamp, we can now record the evoked potentials that were generated with the cortical stimulator and recorded from the other sides. So we have to enable, for example, here the trigger. This is the digital input, a TTL trigger, which is usually between 2.5 and 5 volts as a high trigger, and then by that we can understand that there has been an external event from another device, and by that we can synchronize the devices. So now that everything is configured, we can now define the visualization options. So if we want, for example, to have a visualization filter which is not present in the stored raw data, so the raw data is fully DC coupled and without any filtering, and a good sampling rate is between 1200 Hz and 2400 Hz. So we can test the recording and then store the recording in a file. And once the recording is ongoing, we can then receive the triggers as a vertical line here in red from the stimulator. And we can already see with the pure eye in the raw data the evoked potential after the trigger line. And now when we show that as an average response on the evoked potential scope, we can see in the matrix plot that there are some channels, especially channel 9 here, which shows a very prominent N1 peak followed by an N2. So now how we can have a look where this actual happens. So for that purpose we can load again a montage, and understand the topographical arrangement of the evoked responses, because we are actually interested in the connected network and not only into the evoked potentials that are next to the stimulation site. Because when we consider that there is the stimulation entry point, then maybe the surrounding electrodes are actually contaminated with the stimulation artifact and not showing the pure physiological response of the cortex. So for that purpose, we can actually highlight the stimulation entry points, and we can change the visualization of the axis so that we here understand where and how strong the evoked potentials occurred on the cortex. So here on the medial side of the ventral temporal lobe, so the parahippocampal gyrus, we have two stimulation points in red dots, and we can see that the surrounding electrodes are actually showing a very strong deflection, but also distant electrodes, even on the frontal lobe, we have some evoked potentials that are now interesting because they are indicating a connection between the two regions of the brain. And when we now know the functional area of the stimulated sites and the functional category, so to say, then we get an idea of which parts of a functional network have been revealed. So before I talked a bit about the polarity of the stimulation, and here we can now see in red the positive and in blue the negative stimulation. And we can see that there are some overlapping traces and some diverging or divergating sites. And basically when we can see that, like here on the ventral temporal area, the artifact is just the opposite, but the evoked response is completely overlapping, then this is a very strong indication that the response is a real physiological response and not a pure, for example, volume conduction effect of the stimulation current. In contrast here, next to the stimulation site, we can actually see that there are some electrodes that are either completely shifted with an offset or even drifting into another direction. That means that the stimulation causes a very severe artifact, and we should actually reject them from the interpretation. So now we want to understand how good this overlaps with the functional maps, for example, obtained by task-related brain activity. So here now we see different phases that were presented to a patient, and while the patient sees, for example, here it's in the baseline, there's not a lot of activation going on from this fusiform site, but once the patient sees the repeated presentations of the phases, then we can see now very strong activation in the broadband high gamma frequencies. And we repeat that here, and you can see that this C-score trace nicely reflects the block design paradigm in red and in blue. So now when we localize this on the brain, we can see here the activation patterns on the fusiform gyrus. And so now when we select one subject that we also want to stimulate, then we can here now select, for example, a stimulation site on the posterior part, so the occipital cortex. And so now here we have a blind spot. This is the stimulation entry point, and here around it we have a very strong evoked potential. And then also on the ventral temporal cortex we have these evoked potentials that are connected. And when we look at the high gamma activation, then here we can see that the stimulation sites actually showed a high gamma augmentation during the presentation task of the phases, and also in the surrounding regions. And interestingly, we can see an phase-related N250 here, and also we can see phase-related high gamma activation. And now when we compare the CCEPs with the evoked potentials and the passive mapping, then we can actually see that they nicely correlate for the connected and eloquent regions. So now the question is, can we do the same thing for the epilepsy network? And so to understand this, we can go now to a case that was published by Dr. Kamada in 2017. And at that time, the patient came to the hospital, the Asakawa Medical University. And this was a patient, 20-year-old man with a 10 years history of generalized convulsive seizures, and there was no abnormality in the MRI, but there was a 3 Hz spike and wave pattern during the seizure occurring on the whole frontal cortex. So then the question was basically for the bipolar occurrence of the epilepsy, where the epilepsy comes from and how it propagates. And from the intracranial ECoG monitoring, we can actually see frequent bilateral spikes and waves, and with the right hemisphere indicating a slightly earlier change here in the vertical line. So we can see here that on the right hemisphere in the frontal area, the epilepsy started slightly earlier to fire. And when we look in detail which side was the earliest, then we come to 74 and 75 here. And those were now the entry points for stimulating and understanding the network that is connected to this epileptogenic focus. So now we can see again the negative and the positive stimulation polarity in the raw data visualization. And when we average, we can see again this evoked potential clearly with an N1 and N2 in channel 9 and surrounding. So when we now look at the stimulation sites here in yellow, then we can actually see on the contralateral hemisphere this strong CCEP. So now this indicates that as we have seen it in the epilepsy monitoring, that there is a direct connection between the two hotspots that have been observed in the monitoring. So this is another visualization. Here we can see when we stimulate here on the right frontal cortex that we get here this strong evoked response. So this is now the N1 in channel 9 and surrounding. So now we want to understand where this connection is actually located. And so basically to do that we can utilize tractography or diffusion weighted imaging. And so from recent studies we know that, for example, the CCEP is actually related to the properties of the white matter. So for example, from the tractography we get the path lengths, and we can see that there is a loose correlation between the N1 latency and the fiber length, that there is a very strong correlation between the N1 voltage and the fiber length, and that there is a correlation between the FA value that we have from the DTI image and the propagation velocity. So this also has an effect on the latency. And so now, since we have a cross hemisphere connection, we need to understand the fiber tracts through the corpus callosum. And here to see with a single tensor technique, usually we get only the main fiber direction, which is an arc fiber in the corpus callosum. And if we want to really get the transversal fibers, we need to understand or we need to utilize a multi-tensor technique, like a 2-tensor tractography. And here you can see in blue how a 2-tensor tractography can actually add the transversal fibers. There are other studies that actually showed that an unscented Kalman filter tractography based on 2 tensors can actually best reveal the transversal fibers. So here from the publication from Wang et al., we can see that if we have an unscented Kalman filter with 1 tensor, still we get the main U fiber or arc shape. But if we add a 2-tensor technique, then also we get the transversal fibers. And to date, this should be, together with the probabilistic tractography, yield the best reconstruction results. So this is now an example from 3D slicer, where we actually have the thresholds for the FA value and the 2-tensor unscented Kalman filter tractography model. And then we can, based on the tractogram, define the regions of interest. So here we have the stimulation entry point. And this is kind of one intersection that is mandatory. Then we have the propagation through the corpus callosum. And then we have the CCEP target point, which is another region of interest. So if all the 3 regions of interest are actually crossed by the fibers, then the fibers will be considered as connecting the network. So now let's have a look how this monitoring looks when we visualize the fibers. So here now with the g.HIsys toolbox in Simulink MATLAB, we can show in real time the responses for the stimulation. And this is now an intraoperative recording. And in the intraoperative recording, the indication, so the indication for the surgery was a corpus callosotomy here. And the entry point for the stimulation was the mid part of the corpus callosum, and the resection direction was towards the genu, the tip of the corpus callosum. And what we can now see here is how the evoked potentials respond to the stimuli, or how the evoked potentials are shown in response to the stimulation. And now, through the progress of the resection, we can actually see when parts of the corpus callosum have been removed, that the connection is still given for the mid part of the corpus callosum. And then when we reach the anterior part of the corpus callosum, we can now see that the CCEP actually is diminished. So what we can see for the first few average iterations are the electrical artifacts from the stimulation and the brain baseline drifts, basically. And after a few repetitions, basically after 10 to 20 repetitions, we are confident that there is no evoked potential anymore. So now you can see the surgery from Dr. Kamada here, when he is actually resecting the corpus callosum, the white matter. And now we can see here the evoked potentials. Here important is channel 9 again, through the progress of the surgery that can be monitored. With the neuronavigation probe, we can see where in the corpus callosum we are now located. And we can see that through the progress of the surgery, if we now reach the anterior part, that the evoked potential has been diminished. So this was a very nice indication and biomarker that we could utilize as a confirmation that the network that is interconnecting the epileptogenic zone could be disconnected. So here again, as a summary, this is the corpus callosum, and here we have the direction of the surgery. And when we start at the midpoint, we can clearly see the N1 part of the CCEP. And here, when we reach the genu, the anterior part, then the CCEP has been diminished. And this nicely overlapped with the main fiber bundle that has been identified by the 2-tensor tractography technique. And later on, we also published a summary of 14 patients that underwent this combined treatment of the ECoG monitoring, the CCEP and tractography. So I will give another example. So here there's a 23-year-old epilepsy patient, and here the treatment strategy was actually a hippocampectomy after showing the hippocampal sclerosis. And here the epileptogonic foci was on the right frontal lobe and right mesial temporal region. And the pathological CCEP was actually shown on the right lateral temporal lobe and the right frontal lobe. So here we have the entry point of the resection. Again, we can see here now the evoked potential. So here the N1 goes into the positive direction and the N2 in the basically into the axis is flipped, and then we can see after the disconnection of the hippocampus that we have the CCEP that diminished. Another case is a 15-year-old female epilepsy patient, and here the MRI showed focal cortical dysplasia of type 2, and in the ECoG monitoring again we had bipolar frontal epileptogenic foci. And now we can see the pathological CCEP on the left premotor area when the focus on the right side here, actually this indication is flipped. So here we have the right side with the stimulation entry point, and here on the left premotor cortex we have the main deflection, and also here on the lateral frontal cortex. So the treatment strategy was again a corpus callosotomy. So here we have the entry point for the resection, and now the surgical direction was towards the backside, the splenium. And now first we can see the PME CCEP, the PME CCEP, and then after about 80% of the progress of the corpus callosotomy, the CCEP vanished again in the intraoperative monitoring. So taken together, we have the combined treatment of tractography, ECoG monitoring, and intraoperative CCEP monitoring. And in 14 patients, basically 13 had a favorable outcome, and one case showed a poor outcome in terms of the seizure after the surgery. However, in that case, also the CCEPs remained after the resection. And now we're actually working on improvement of the whole CCEP screening to simplify the procedure and the complexity to obtain the evoked potentials, because initially when you have no start point, then it's very difficult to really understand what to stimulate and what the responses mean. So therefore we try to actually automatize the CCEP mapping method, and by adding here the switching unit, we can then programmatically iterate from one electrode pair to another, and then sequentially stimulate and record the responses from the brain. So here in this example, you can now see a fast forward replay of such a network screening. So here in the left side you have the raw data visualization with the stimulation plus and minus electrodes. Then we have the evoked responses with the stimulation artifact here in the raw data scope. And then in the middle you have the evoked response average matrix of the individual channels. And on the right side you have actually the overall topographical outcome of the area under curve of the evoked potentials. So basically we can compute the RMS value from the EP and then visualize it as kind of a connected network. So in yellow we have the stimulation sites again, and in red is the connected evoked potential to the stimulation. So we have always a very strong deflection next to the stimulation site, but we have also frequently occurring distant related areas. And what is very nice, for example, so these are visual areas. Here we are now stimulating the language area, and we get some interconnection, for example, here in this side with the parietal lobe. So this is very interesting to understand how this is related to the language area. And here we can see the Simulink model that can be actually used to control the cortical stimulator, the switching unit, and the amplifier together, and to do the online processing. So one of these blocks is actually used, for example, to average the signals. Another block is used to create the biomarker for the evoked potential RMS value, but this can be of course substituted by any other algorithm, like for example slope or peak detection or any other spike detection algorithm that fits here for the network visualization. So this is basically the overview for the CCEP mapping and the relationship to the epilepsy network and how to visualize and navigate through the surgery. So if you have any questions, please let me know.
Thank you very much, Kapi. Dr. Pathak is asking how, can you hear me? How can white matter tractography be used to map functional system and subsystem in the human brain and their interrelations?
Well, for the interpretation of networks and systems, it's always the difficulty to have a start point. So like here, when we now want to understand a cortical, so which is a good example. So when we know that here, for example, an area is associated with visual processing, then we can understand which parts are connected. So based on the a priori knowledge, and this a priori knowledge can be obtained by, for example, the high gamma mapping like here, or by the cortical stimulation as we had it before. So when I move to the stimulation mapping here, so here there is a fusiform phase area, and first, of course, we had an effort to identify the specific functional area of that part of the brain. And once you have identified these parts of the brain, and this can be now an eloquent region, task-related change, or a task-related specific brain region, it can be also a region that is related to the epilepsy, but you need to know the label basically of the start point. And once you have the start point, then you can reveal connected parts. So first of all, if you have the relationship between the different modalities, like we have it here, then we can understand what the CCEP networks actually tell us. So basically, when we understand that we have a very good relationship between a visual processing pipeline of phases, and we stimulate a part of this brain of this network, and the rest of the network will revealed, then we have a very good indicator how this network is actually established. And what remains is then that we understand based on the white matter tracts how are these networks interconnected, and basically which are the main fiber bundles. And here it's getting very difficult actually. So there's a big palette on different tractography methods, and actually for different use cases. So for example, in our use case, the transversal fiber through the corpus callosum, the unscented Kalman filter to tensor tractography turned out to work pretty nicely. However, the problem is if you select different methods for different use cases, then of course there's the risk of overfitting if you try many approaches until you reach one point. So it would be really preferable to have one generalized technique for tractography that really reliably shows us the fibers between different parts of the network. And once we have this established, I think this is a very powerful tool. But there is still a lot of work to do to really understand, for example, for different language areas, for motor-related sites, for the epilepsy network, for within hemispheric arc-shape fibers, for transversal fibers, which methods can be really utilized to have a generalized and robust outcome of this interconnection. So another aspect is, of course, and I think with stereo EEG this is possible to also utilize white matter stimulation. So this would be actually a counter test, which we did not perform yet, but I'm very much interested in that. When we stimulate white matter locations and then reveal the fiber tracts that are crossing those stimulated regions, how we can actually get the connected cortical regions, and what is the meaning of these cortical regions, and are they eloquent for specific tasks, and can we explain, for example, white matter CCEPs, and also the passive and pan-field method mapping results with that. So that would be the next step that we have to investigate to really make this a powerful tool.
Other question is, how does white matter tractography contribute to the segmentation of specific white matter pathways and their connection to functional units of gray matter?
Well, I think this is, if I understand correctly, basically a similar question. So gradually we have, for different functional regions and different gray matter parts, we have to understand which tractography technique basically gives reliable results that can be explained, for example, by the cortical responses. So we now have the biomarkers for different tasks, for different eloquent regions, for different pathologies, and now basically we have to screen through the whole palette to understand if this can be actually used.
David Bauer is asking regarding the previous presentation about sensory crossover. Have you now in this lecture demo eventually gained some insight into that using Kalman filters in practice and specifically sensor fusion?
So we didn't test this with any sensory data. I think that we have to connect later on to kind of synchronize for sensory inputs here. So I can only basically talk about the network for the visual perception, but not for the sensory input.
Are there any other questions for Kapi?